Welcome everyone. We have, I think, somewhere in the order of 1,000 people that are tuning in to see us this morning, which I think is fantastic. And really, from my point of view, just wanted to give a little bit of an introduction and a little bit of an understanding of what we're trying to achieve with this festival. Because from my point of view, I think it's about 15 months ago now that I remember last going to a major overseas healthcare festival, back when we still could do those kind of things. And in the last 12 months, some of those big conversations that we're probably used to having around healthcare infrastructure, digital healthcare, the sort of workforce crisis, moves towards USC, have probably slowed down a little bit, because necessarily our healthcare systems have been focusing on dealing with the coronavirus and dealing with some of the big global events that have gone around that, the development of the vaccine, and now the rollout of that vaccine. But what we've started to see in the last 3 or 4 months is people starting to have those conversations again about what our health systems look like beyond coronavirus. And really, that was the purpose of putting together this festival, to start allowing that debate to take place again about how some of those big issues in healthcare will develop, and how those aims and those goals that we have will have changed because of coronavirus. Digital healthcare, for example, has probably been advanced hugely by the fact that we've all been stuck at home and needing to have our healthcare delivered to us rather than going to it. But certainly our topic this morning, which is the funding of infrastructure projects in Sub-Saharan Africa, that continues to be a major issue. And it'll be interesting to see over the course of this debate how that discussion has moved on in the last 12 to 15 months. So without any further ado, I'm going to bring in Barry Francis, Healthcare World's infrastructure correspondent, who will be chairing this morning's session, and we'll introduce the speakers. Barry, over to you.
Hello, as Steve said, I'm Barry Francis, and I'll be chairing or moderating the session this morning. The topic, as Steve said, for the hour and a half that we have together, is financing healthcare infrastructure in African countries. So by financing, we're looking both at the funding, where the money eventually comes from, and the financing, who pays for who provides the initial capital costs. And the emphasis will be on the money side. But in order to understand or start to think through the money side, obviously we need to think in terms of the new thinking that's developing in relation to design, how design has to fit into systems, looking at those systems, and then looking at with those needs, how do we then convert those needs into demands? And by needs, I mean there are obvious needs everywhere, and by no means least in African countries, for improved healthcare systems and healthcare infrastructure. But how do you convert that into demand? By which I mean identifying what can actually be provided and paid for, whether from the public or the private purse, and then looking at the structures that are needed to deliver that, and the impediments and opportunities to go through that process to actually deliver healthcare, with healthcare infrastructure, the buildings being but a delivery vehicle for that ultimate aim of improving the life and the length of life of citizens. So if we take those issues as the broad themes of this morning, we will then on the panel we have Richard Cantley from Mott MacDonald, who will lead off talking about some of the technical and design issues and the systems issues. Moving through to Ralph Martin from Contractor Group, looking at some of the issues around procurement and how you actually create the supply chain and what is needed to actually supply the infrastructure. And then Chris Bonnet from GE Healthcare, who's worked on many projects in Africa and elsewhere, looking at the equipment side, the financing side, and the broader issues as far as GE Healthcare are concerned. Then moving to a contribution from Nicholas Crisp. Nicholas is taking up a role in the incipient, wrong word, in the new social insurance scheme being developed in South Africa, but we'll be looking broadly at systems and the issues around what type of infrastructure and how we deliver them. And then bringing this part of the session together, Oloranti Dirty from Afrexim Bank, who will be talking, among other things, about some of the products which Afrexim Bank are delivering I paused because I realized I've missed out Paul de Rita, which is really embarrassing. But I will come back to Paul and explain his role in just a sec. Oloranti bringing the issues together in terms of some of the products which Afrexim Bank are developing to tackle some of the issues we'll be raising. But before Nick speaks, but after Chris Bonnet speaks, there will be a contribution from Paul de Rita. Paul, who at one time was running the healthcare advisory team at IFC in Washington, will bring again the financing and some of the other practical aspects to how we make these projects work. That'll take the first half hour, 40 minutes, depending on how strict our panelists keep to their timetable. And we will then turn this into a discussion around the panel, talking about the various issues which we've mentioned and other things which crop up. And by crop up, I mean including those things which I would ask anybody who's watching us to feed in on the chat line. And then I'll be picking up the questions or the comments, the points of view, not just questions, from the chat, and feeding that into the panel discussion. And then we'll bring things to a close, and hope by the end of that, I hope that some new ideas and some new, at least beginnings of solutions might emerge. So that's how the morning is going to pan out. And so if I may, I'd ask Richard Cantley to start the panel discussion, or the panel offering.
Okay, thank you, Barry, and good morning, good afternoon, or good evening, wherever you may be around the world. So I am Richard Cantley of Mott MacDonald. So Mott MacDonald are a global management, development and engineering consultancy. And we deliver services across a wide range of health and healthcare projects. So I am the global health portfolio leader. So I run the team that delivers both aid-funded health programs in low and middle income countries, as well as the healthcare consulting team, which is the upfront services we provide to healthcare infrastructure. Mott MacDonald do get involved in also the engineering and project management of hospitals and healthcare infrastructure. So in terms of, just thoughts around Africa, so this conference is very much about, financing future infrastructure. But to me, the key thing is thinking about what is the right healthcare infrastructure as we move forward. So we need to design the right infrastructure and then think about what is the methods we can use to finance and pay for that. So it's really important, I think, to think about what is the infrastructure before we start thinking about the financing of it. And I think there's a real, really good opportunity for Africa really to rethink what healthcare infrastructure is and what we mean by healthcare infrastructure. Thinking first about, as the demand increases across Africa, there's really an opportunity, first of all, around about the health systems, and making sure that we are very focused around about healthy populations and, how we do as much as we can to really promote the health of populations. And that is both in terms of preventative measures such as public health interventions and, thinking about the health implications of all infrastructure projects and how they contribute to people's health and well-being, as well as then what is the healthcare infrastructure we need for when people fall ill or need healthcare interventions. In terms of the healthcare infrastructure itself, I think we really need to digitally disrupt the thinking of what that healthcare system is. Healthcare for a long time has been quite slow in adapting to digital change and digital disruption. But I think we've seen much more of that since COVID, with a lot of pace now around about that. And it's really, the opportunity that presents, thinking about, how much of healthcare can we deliver outside the hospital? What is the digital disruption to the healthcare systems? And that all, adopting that mindset results in you still need to, put in place a huge amount of physical healthcare infrastructure. But I think the size and nature and type of that infrastructure is very different than if you start from a position of let's build a hospital. And I think somewhere like Africa, is an opportunity really to bound ahead with this sort of thinking, and doesn't have so much legacy systems that they need to design around, which some of the more sort of developed healthcare systems in countries have around the world. So I think, it's about that mindset. It's about hospitals for the future. What are hospitals fit for the future? Well, picking up on the digital strand, it's the digital healthcare system, but then within that, the digital hospital. And what is a digital hospital? There's a lot of thinking going on around about that. It is about thinking about net zero, particularly given the linkage between climate change and the effects of climate change on health. It's about flexibility and adaptability and how we really embrace that. There's an opportunity to implement more standardization in how we design hospitals. We're seeing around the world a lot of moves in terms of modern methods of construction and all the benefits it brings around about health and safety, speed, quality, etc. And then last point I would put under future hospitals is probably, designing hospitals, thinking about health and healthcare, not just healthcare. So how can hospitals, in themselves contribute, wider societal benefits and to the healthy population agenda. So that's just some of my thoughts around about, it's about the health system. It's then about digitally disrupting healthcare systems and then delivery of future hospitals within that. But I really think we need to be clear about what we're trying to put in place and then think about how we need to finance it. Thank you, Barry.
Thank you very much indeed, Richard. Thank you. Ralph, do you want to now lead on some of the thoughts around how you then have to engage with the supply chain, and then how how you're then relating to financing support such as the ECAs?
Of course. Thank you, Barry. Thank you, Richard. Thank you so much. It's a pleasure to be part of this conversation about Africa. Well, I run a busy procurement department here in the UK. Contractor has over 20 plus years. We started in Africa in 2011 to build an airport hangar. We established here in the UK in 2016, and this led us to a number of bigger infrastructure projects. The great majority of them are EPC, from ring roads to airport, university, hospitals. Right now, we are being supported by UKF to Konfu Maternity Hospital back there in Ghana, which is 550 beds. And I'm much more here on the procurement side. And we have been facing some issues along the way, but nothing that we cannot overcome. Yeah. So someone asked me once, are there common issues which discourage you? I said, I would not say discourage us. Yeah. However, makes the whole process slightly challenging is having to convince British and European suppliers that Africa is a market worth expanding into. Yeah? So these barriers, their concerns, is some of them has never exported before, or they are kind of afraid with export documentation, bill of lading, all that heavy paperwork, but it's kind of a fear of the unknown. Yeah. So some of them told me that language, it could be a barrier, or payment risk. So, but most of cases, we work with advance payment, as long as we have guarantee from the other side, which is pretty much clear here. And the good things, how do we engage, yeah, with the suppliers, with the supply chain to make the things happen? Actually, it's a flirting game. So in some cases, it takes a while to convince them, the supplier, how easy it is to export to Africa. I like to tell them that it's kind like a domestic internal sales, nothing different than that. So contractor deals with most of the complex issues. For example, contractor has a logistic department where all the documents can be prepared to help British suppliers to export. So there's no big issues here. Yeah. So I suppose suppliers could just trust us to do the heavy work. Yeah? So there's no fuss. And as I said, it's kind of internal domestic sales, apart from the fact that goods will be exported to Africa. Yeah. And here, I could not forget HWF and DIT as well, because they are introducing us to the best of Britain in terms of suppliers, and they are doing this things to us, supporting us since the beginning and bulldozing all the obstacles, which is pretty much good for contractor, being a Brazilian, British company, and having on our pipeline good projects, especially hospitals in Ghana, either by HWF or SACI, which is Italian ECA as well, export credit agents. And that's it. This is my overview for in terms of a procurement issues and challenge that we are facing here. Thank you very much.
Thank you, Ralph. Thank you very much indeed. And just moving on, keeping on this theme of equipment and supply, but perhaps also more widely given what GE Healthcare do. Chris, what are your thoughts?
Thank you, Barry. Thank you, Ralph. Good day to all. I guess we're very fortunate as GE Healthcare. We've got over 700 people based in Africa. We've been an African company, an African English company for more than 15 years now. We supply everything from monitors to MRIs, but we ceased to become just a technology company a few years ago. Healthcare infrastructure in Africa requires a lot of infrastructure development and not just the simple placing of equipment. Our ethos at GE Healthcare is to be as sustainable as possible. And that means sustainable from a financing perspective, from an equipment and technology perspective, clinical education and training, and skills transfer. The placing of equipment doesn't actually solve much of Africa's or any of the emerging markets' healthcare needs. To really help a hospital or a health system or any form of infrastructure, you've got to have people on the ground to support, train, educate. And we think we've done that in spades in Africa. So 700 people on the ground. We have our own education teams, installation teams, and our job is to help customers, both public and private, keep their equipment up and running, to give great guidance and advice on healthcare infrastructure development, and to support our customers on the long-term basis. So we're pleased to work with many construction companies around the world. We help them realize what the project can look like from a technology perspective. We help ministries of health design things like hub and spoke models. I think Richard mentioned earlier on that healthcare is changing, and certainly healthcare in Africa has you know, the triple burden of disease. We have pandemic, we have NCDs, and we have communicable disease as well. So primary care is essential. Our hospitals in Africa are fantastic, but need more help and support from equipment training. And G Healthcare does its best to try and meet all of those needs. We work a lot with the financing institutions around the world. So I think Ralph mentioned UKEF. We are just completing our third UKEF project in Sub-Saharan Africa, and there are more to follow. We're present in 26 of the 54 countries in Africa with physical G people on the ground. And financing is a really key part. I think the COVID-19 pandemic has shown that unfortunately most of our countries are quite heavily indebted in any event. So intelligent financing, intelligent multilaterals and development banks and ECAs are critical to growing healthcare infrastructure. We do our best to work with all of those parties and players, both public and private, to create good healthcare working infrastructure. I could talk for hours about this. I won't. It is a favorite topic of mine. I'm a Kenyan by birth and background, so we tend to do a lot of work in East Africa. And as one small example, you know, we're currently building a hub and spoke oncology model for the Kenyan oncology system. I think Kenya is a very forward-looking country. There are many in Sub-Saharan Africa that are doing that. And we're supporting the Ministry of Health to do a number of things there, which is everything from pathway design and clinical design through to the physical development of buildings and infrastructure. So as a summary, G Healthcare is a technology company, but our real job is to help public systems and private systems modernize their healthcare. I hope that answers your question, Barry, and I'll now pass back over to you.
Thank you, Steve. Thank you very much indeed. Paul, would you like to sort of then start moving into the more heavily finance-focused aspects of our discussion?
Yes, sure. Thank you, Barry, and good morning to everybody. So in my introductory comments, I want to focus on two things. I mean, yes, let's talk about infrastructure need and the finance that's required to deliver that, but let's also think about the context of health systems across Africa, because I think it's important to recognize the magnitude of the challenge that we are looking at here. And I think we can look back before the pandemic and appreciate and realize that actually health systems across Africa were already under stress before the pandemic. And clearly COVID-19 has brought additional stresses and strains onto an already overstretched system. So there's a huge amount to recover from. I think it's also important to realize that as many African governments move towards universal health coverage, the investment required to do that is well beyond the means of many of those governments. So business as usual in terms of public sector investment will not deliver the types of investments and the scale of investments that are needed across the continent. And just to perhaps share some brief stats in terms of how health systems across Africa may be characterized in general terms. You know, you can see that Africa as a whole spends on average about a quarter of what OECD countries spend on healthcare. And actually governments themselves spend less than 2% of GDP on healthcare. Much of the expenditure on healthcare is made in the private sector and is actually made from out-of-pocket contributions, with some countries being as high as 70%. So again, that model as it stands is not likely to be sustainable in the long term. So looking at infrastructure in healthcare setting is also important to recognize that actually infrastructure investment across the economies of Africa is much more than just about healthcare. So some estimates, for instance, suggest that somewhere in the region of $130 to $170 billion is needed annually to keep still across African infrastructure, with healthcare being a very, very small proportion of that. And at the moment, I think, again, some estimates suggest that Africa is spending only half of that amount. So we're nowhere near the level required to even stand still, never mind develop. So clearly new financing models are required. And those financing models need to come not just from the public sector, but also from the private sector. And indeed, as Chris has already mentioned and others, from multilaterals, from donors, from a variety of different actors, if we are to try and meet some of this challenge. You know, one of the areas that I work in, which is public-private partnerships, is becoming an increasingly popular way of financing and procuring infrastructure across Africa as well as the rest of the world. And that's clearly one way of doing this, but again, one solution is not going to get us the whole way. So we need to adapt a variety of different models, from blended finance solutions through to the typical PPP structures of project finance, and in some cases we need to see how donor financing can be perhaps adapted to deliver long-term infrastructure in the ways that so far we have not particularly seen. So I would say, in summing up my initial comments, it's important that governments retain control of healthcare systems. They clearly have a long-term role in thinking strategically about healthcare and the infrastructure needs. But we also need to recognize that there is a huge role that the private sector already plays. So for instance, I think across the continent, over 50% of all healthcare is already delivered in the private sector. So the private sector will have a critical role to play as well. But clearly, the strategic direction and the leadership has to begin with the public sector, in my view.
Thank you, Paul. Thank you very much. And then just looking at all of those things together, obviously there are huge challenges, and the need, as Paul has just said, the need to develop new products and new approaches to meet the challenges. Could I ask Oloranti Dirty to talk about what Afreximbank is doing? I'm really sorry, I've done it again, haven't I? I've done it again. My list, I was so concentrating on not missing Paul out that I got this completely wrong. Most embarrassing. But Nicholas Crisp is, as I mentioned earlier, who is now smiling at me, and thank you for smiling and not grimacing, Nick, is with the Department of Health in South Africa, and we'll talk more about the systems and his experience in trying to make infrastructure projects work in the context of some countries in Africa. Thank you, Nick. And I'm sorry, Oloranti, for sort of suddenly making you think, oh God, I'm on, when you weren't quite.
No
Thanks,
worries.
Barry, and
Sorry.
thank you, Barry, and good day to everybody. And thanks for inviting me to be a part of this discussion. I'm a South African, and I've worked across Africa in the healthcare system for 37 years. And infrastructure is always a challenge. And we just seem to never be able to get on top of our infrastructure needs. I'm going to build on some of the things that Richard said, because if you keep building and you're unable to maintain, and you build the wrong things in the wrong place, you just create an even bigger challenge for yourself going forward. And we really do need to think differently about what we build, why we're building it, where we put it, and then how we're going to maintain it and what we're going to do with it in the long term. And of course, our population is changing, our epidemiology is changing, and the way in which we deliver healthcare, especially with our focus on primary healthcare, moving more and more to household and preventive healthcare, and the way in which we manage our social determinants of health are changing as well. So what we have been concentrating on in the recent past in South Africa is to have what we call a 10-year health infrastructure plan. It's a top-down modeling program that includes all private and public known infrastructure and uses a GIS, Geographical Information System-based background with population densities, which are weighted for various populations. So for instance, children and women and between the ages of 15 and 35, and elderly people, those over 60, to try and understand where the demand should be coming from, or where the need is in the community. And the whole objective is to find an objective way of identifying priorities. What we now have succeeded in doing is linking this fledgling first stage 10-year health infrastructure plan to what's called the Project Management Implementation System, which is a big nationalized system where we monitor the maintenance, refurbishment, and new builds of all infrastructure in the public sector. And we can then monitor the changing shape of infrastructure, at least within the public sector for now. We do have a very federal system in our country, and sometimes subnational decisions ignore the national plans and ignore the priorities of the country. and have resulted in a number of vanity projects which are politically driven. And once you have those, of course, you're now stuck with the waste of money of underutilized facilities, which you have to staff, or you have to close parts of them or repurpose them. We do have challenges with so many role players. That's health departments, treasuries, works departments, a lot of procurement rules within our treasuries, which are tedious. And finding a way around those is also a challenge, specifically in the public sector. Then as far as trying to understand what it is we build, we have a set of quite detailed norms for the elements of the space within health facilities, and even magnitude, order of magnitude calculators to understand the kind of budgets we should be putting aside for those capital projects. They are quite sophisticated, and part of the problem has been not being able to incorporate the private sector planning. You'll see that's important in a moment. We have economic empowerment requirements, which chase our prices up. We do a lot of purchasing of facilities through tendering processes that get driven by the suppliers because they are paid a percentage of the spend. And that's a design issue that we need to relook at how we do that. The public infrastructure in our country is cash funded from the fiscus, and there's not been enough thinking, as we've heard from Paul and others a moment ago, not enough thinking about alternative financing mechanisms and how to structure blended finance to pay for any new developments. So as was said, I'm now moving into a new role. From this month, I'm responsible for building our new national health insurance. And this is a massive reform program which will run over many years. Obviously, now it becomes important to incorporate our planning for our public and our private sector and to understand the infrastructure in the private sector, which is significant. More than half of all our healthcare in the country is provided in the private sector, and the facilities and the equipment that are available to them is huge. So we have a lot of work cut out for us in Africa. South Africa is no different. And of course, we can learn from one another as we go forward. So pleasure sharing some of these ideas with you now of what we are trying to achieve. I'll leave it at that. Thank you.
Nicholas, thank you very much indeed. Oloranti, for the second time. Oloranti, could you just talk now about what Afrexim Bank are doing? And I'm sure some of that in the context of the points that have been made already. And then we'll open up a discussion more widely. Just on the question, sorry, just to interrupt, on the question of the wider discussion, I've just been glancing at the chat, and it's awfully empty at the moment. I know that there are a lot of people watching us, and it would be really good if not only did people watch, but they participated. So as I mentioned earlier, questions, points, statements, disagreements, do flow them in, and I will incorporate them into the discussion, which will follow Oloranti's contribution. Oloranti, sorry for interrupting you again, but now over to you.
I hope this is the last time.
Yes.
Thank you, Barry. Yeah, let me start off by giving a brief background of Afrexim Bank, who we are. We are a multilateral trade development bank that was set up in 1993 to promote intra and extra African trade. The bank is headquartered in Cairo, Egypt, and we have 4 regional offices in Harare, Zimbabwe, for the Southern African region, Abuja, Nigeria, to cover the Anglophone West Africa region. We have an office in Abidjan, Côte d'Ivoire, to oversee the Francophone West African region, and an office in Kampala, Uganda, for the Eastern African region. We have 51 participating member countries. And just to provide you with a context of, our intervention within the healthcare space, for us, we see a direct link between trade and health, and we believe that it is only an healthy population that can promote trade and economic development. And, despite the fact that Africa has the youngest population of all continents, we also do have the lowest life expectancy rates due to non-communicable diseases, communicable diseases, lack of healthcare infrastructure, a huge gap in the system. So all these have been emphasized by most of my fellow panelists that have spoken. Also, I noted that Paul referred to the huge gap in healthcare, the infrastructure gap on the continent, and the fact that governments alone cannot meet this need. And as such, a DFI like Afreximbank, we've come up with new products and initiatives. We came up with the Health and Medical Tourism Program, which seeks to provide financing to support development of healthcare infrastructure. And under that program, we have debt financing instruments, which is the Construction and Medical Tourism Relief Facility, CONMED, to support the development of healthcare facilities, where we provide debt financing to both government and private sector organizations. Through this facility, we've been able to support the development of diagnostics hospital in 250-bed diagnostics hospital in Uganda, diagnostics outpatient facility in Liberia. We also participated in some of the financing in Ghana for the expansion of public sector hospitals. We also have another initiative under the Health and Medical Tourism Program, which is the Africa Medical Centers of Excellence Initiative. Here, the bank plays a developer role and seeks to bring on board partners to be able to attract both equity and debt financing to be able to develop infrastructure projects. And under that initiative, we are seeking to develop centers of excellence across various regions of the continent. We're starting with a pilot project in Abuja, Nigeria, and we're working with various partners, including King's College Hospital, London. Even GE has been one of the key partners that has been supporting us on that project. We have, finalized the basic designs, and the project groundbreaking would occur in Q4 this year in Abuja, and it's one of the key interventions we've played where we have not typically been a financier, but decided to play the role of developer, decided to leverage equity, and decided to bring in debt financing. Also, furthermore, we developed a product called the Project Preparatory Facility, and this is to provide seed funding for the development of feasibility studies to make project bankable. I'll be speaking more on this later, but all these are products that we've come up with as an institution to be able to support the healthcare infrastructure across the continent, because it's quite clear to us that government alone would not be able to meet this need, and it would need both governments, private sector stakeholders, development finance institutions like ourselves, and organizations who play a key role in the healthcare sector to put all our heads together to be able to bridge this gap. Thank you.
Thank you very much indeed. So I'm sorry, I was just looking away because we do in fact have a number of questions and points that have arisen. I was just looking at those that have come in. So just to pull out some themes that we can start talking about before I start feeding some of those questions in. I think some of the key points that were made and which are being reiterated by the wider group who are watching us have been about the integration of healthcare systems and infrastructure. So the point that Nicholas made in terms of the building and the difficulty of making sure those buildings are actually what are needed. And that ties in very much with Richard Cantley's point around looking at, the opportunity, and it may not seem like an opportunity at the moment, but the opportunity of any developing healthcare economy is effectively the possibility of leapfrogging leapfrogging from where many of the more developed health economies are and are kind of stuck because of the established ways of doing things, or the sunk investment. And I suppose the danger, which a number of panelists referred to, of effectively, and Nicholas in particular, of having sunk infrastructure expenditure and capital commitment into a project which may not have been fully thought through, or fully understood in terms of the whole system, that in fact African countries could be missing a trick. And that then got linked in, those thoughts in my mind, and have come out with come into some of the questions, were around, so Paul's point, which makes perfect sense, but which certainly one observer has questioned, was, so to what extent is this dealt with by government? To what extent is government, one suggestion is that maybe government is too hamstrung, and that actually it's going to have to come from the private sector. And the question then is, how on earth can you have, to my mind at least, is how can you have a a cohesive national policy, or indeed picking up on Randy's point with the project in Abuja. Do you actually need to look at this thing in a Pan-African way, which brings in government-to-government issues? Lots in there simply to spark some discussion, so not to ask people to answer specific questions, but taking that bundle of issues together. Who wants to have a go at trying to cut through some of this? I think Paul is looking distinctly interested in doing that. If people don't volunteer, they will be volunteered. It's the only way to make this work.
Great, thanks, Barry. Appreciate it.
We're all friends for.
I think clearly a lot to unbundle there, but
yeah.
And again, maybe to start with, my point about me seeing governments being primarily responsible for this, and it sounds like that's at least raised some degree of disagreement with the audience, which is absolutely fine.
Yeah.
I think that to my mind, there isn't a single solution here, right? This isn't about saying, here's the right way of doing it, and let's all just stand behind this. There are a myriad of different ways to approach this. There are a myriad of different solutions that will have to be adopted. And it will involve the public sector, it will involve the private sector, it will involve civil society coming together and working out which of these models make the most sense in a particular context. And when I talk about the public sector being responsible, in my mind, it's really in the context of driving forward universal health coverage. That is something that is being driven by governments. And so if that is a strategic pillar of a government, then you can't then stand back and let the health system as a whole go in its own direction. You have to provide it with that direction. You have to provide it with that leadership. And actually, ultimately, you have to provide it with regulation and oversight. So that, to my mind, is the role of government, not necessarily to deliver healthcare services 100%. So that's one aspect. I think when it comes to infrastructure and whether we think about whether it's leapfrogging, whether it's using digital technologies much more than we do now, I think that clearly is an area where we are beginning to see some interest in Africa. So there are examples of, and I've certainly spoken about this before, Barry. Look at places like Rwanda, who have adopted some of the digital technologies to provide healthcare services to more remote populations, and therefore avoiding the need of the population to travel to either big urban centres or a need to provide much more in built infrastructure in those urban centres. So some of that, I think, does allow us to start looking at healthcare delivery in a new way. But what is also clear is that hospital capacity as a method of delivering healthcare will still be needed into the long-term future, as far as I can see, certainly. And the starting point for Africa is that they are very, very low capacity when it comes to hospital beds. So, I think overall, in most countries across Africa, the beds per thousand, which is usually a good measure of hospital capacity, is below 1. That compares to an OECD average of about 4 or 5, for instance. So there is a way to go in dealing with both normal infrastructure, if I can call it that, but clearly we can learn a lot from new technology as well.
Yeah. Nicholas, sorry, just picking up on some thoughts. So Paul just mentioned Rwanda, where the projects he referred to, I think, are linked closely to the new social insurance arrangements being brought into Rwanda. And then that also ties in with some other points that have been raised in terms of collection of data and the ability that how do you know what you need if you don't have the data to identify that, and how do you prioritize? And just one more point before I am bundling things deliberately to try and let people come in at what they want to come in on. The other aspect which you touched on, Nicholas, was procurement. And how do you actually structure, having worked out, it seems to me, how do you work out what you want? And having worked out how you want, how do you actually make sure the procurement delivers that? I mean, certainly working in the UK, and I'm sure a few people will be familiar with this, you see sort of stated desire for new ideas, new ways of doing things. But when you actually get down to the procurement, you see evaluation criteria, which are all about how did you do it last decade, not how you're going to do it in the next decade. Do you want to sort of take that bundle of questions and then perhaps other people can chip in at things you say?
Okay, sure, thanks. So I think the starting point from the way I see things is that government has a responsibility for stewardship for the system and must put the framework in place and decide what direction and shape a health system is going to take. Every country is different. Some are more federal, some are very unfederal, some are very rural, some have got a lot of urban areas. Every single one is different. We all have our own historical legacies. We have infrastructure that exists that you can't ignore. We have population movements that you can't ignore, and we have aging populations and young populations and so on. But somebody needs to decide what the policies are around the way in which we're going to deliver healthcare, and government must provide that leadership. In some countries, all maternity care is provided in clinics. Now we hear Ghana is building a big maternal hospital with 500 beds. The women need to be able to move there, so I presume it's in Accra where there's a concentration of population. But if you have a policy that requires all women to deliver their babies in hospitals, you need a lot of hospital beds and a lot of maternity care. Every time you create facility, you're not creating just the infrastructure, you're creating the need for personnel to run that facility, you're creating a need for medicines, transport, costs and expenses to the patients and so forth. So regulating that and making sure there's structure to allow the innovations of the private sector is still a requirement. But if you do it in isolation as a government, you're definitely going to make mistakes. As far as digital technology is concerned, I'm an absolute proponent, and I strongly agree with what Richard said about using the digital opportunities. During COVID in South Africa, we have had an absolute explosion of digital capabilities. Lots of little systems are now finally linked. We finally got traction around our interoperability of systems across public and private facilities. We've got the interoperability standards frameworks agreed to, and we are now able to start putting that data into big data sets where we can use the data to understand who is using the health services and who's not. But if you don't plan and you don't regulate, you end up with the real problems we have, where our private sector is a free market system that drives itself, and it sucks the resources out of the public sector and creates an even bigger dichotomy in the healthcare. You can avoid that if you start to use the capabilities that we have. And today, with blockchain and other technologies that are available, with improved satellite linkages, better networks, fiber linkages, I mean, we have huge distances in our country, so fiber is a problem for us, but there are other ways of networking our data and protecting our data. You can definitely provide more healthcare in a decentralized manner than we were able to do or we were planning to do in the past. So I think every country will have its own objectives. You have to work intersectorally. You can't have networks if you don't have a technology department who works with you. You can't erect a facility if you don't have water and electricity at that facility. And you can't have any facility that's useful if you don't have the staff to staff it. So I do think there's a strong role for government. There need to be forums where the players get together, and where the private sector has its strength is in the innovation of doing things efficiently, smartly, and because they are held directly accountable by feet that walk in and out of their facilities, they have to do it right and safely. How we pay for all of this, of course, is a serious problem because our economies are all in trouble. So we need to design smaller, smarter, more decentralized, less grand, as we heard from Richard, also starting to use more and more standardized construction, the ward structures. You don't need architects to be redesigning every single facility every single time. I think I've hogged the platform for a long time now, so let me give others a chance. Thank you.
That's really helpful, Nicholas. One of the issues that you mentioned, I just want to was you just mentioned were absolutely rightly, but the need for training, the need for people, the water, the electricity, the planning, the digital aspects, the infrastructure to deliver the digital aspect. Of course, it's really easy to say the word digital. It's rather harder to actually make it work. And also to make, as someone who's just sent a point in, has made, and also people need to be willing to use the digital. So they'll, in the UK, you'll have a sort of the age divide, but in other places, different divides. So just generally, in either people who worked in government or people who work supporting or contracting with government, to what extent do we think that there's so many silos in any government, and if you're going to finance something, you need to understand the whole thing, and you need to have confidence that it will all come together and stay together if you're doing long-term finance. I'm just wondering what thoughts are on how you make that work. Is the answer to sort of think big but design small, or what? Does anyone have any thoughts on that?
Just a brief response from my side is that we haven't solved all the problems. There are still people who like to operate in silos because it's a comfort zone. Yeah. But you have to consistently work at breaking the silos and building the relationships. And sometimes the bridge breaker or the bridge maker is someone in the private sector. Because, for instance, if we need to work with our technology agencies and our telecommunications departments, it may be more difficult to us to convince them because there are other competing demands. Whereas if there's a private provider who's pushing them, or a new initiative that's pushing them. So we do need to build those forums and use every single person we possibly can to try and find ways to do things together. We're a water scarce country. If we don't work closely with our water department, there's no ways we can erect a facility outside of a major urban area. But we still have close to 50% of our population living in rural areas. So there's no easy solutions here. You have to work hard.
Yeah. Talking of, sorry, did anyone else want to make a point on that silo point? Just then moving on and looking at silos in a slightly different way, there's an interesting point here made around the potential role of the African Union, Africa CDC and so forth in influencing policy and perhaps implementing it. Olorante, you probably have as much experience as anybody in the issues around pulling different governments or different multilateral organizations together. What's your thought? Is this a nation by nation thing, or is there real benefit in Pan-African approaches, and what are the best organizations for making that work?
Well, I think there is a real benefit to Pan-Africanism. I think there's real benefit to coming together. A case in point is the Africa Medical Center of Excellence project that I mentioned to you. When we set out to say we wanted to help, upgrade infrastructure across the continent, of course, we couldn't do it in 51 member countries. It's actually absolutely impossible. But what we thought of was a regional approach where we bring together, countries within the region and kind of help strengthen the infrastructure across the region. And one of the key things we had to do quickly was to identify key stakeholders we needed to speak with. And they were, of course, in the governments. We needed to speak with people in the ministries of health across these countries. We needed to speak to the Africa CDC, which was, a Pan-African organization. We needed to get them on board as, the outfit within the AU that is responsible for healthcare. And so, bringing all these stakeholders on board involves, bringing to them the key benefits of, supporting, this kind of project driven on a commercial basis. Because, if they don't see the interest for them, if they don't see what is in it for them in the long run, you do not get their active participation or support. For example, with the countries, what we needed to do was to say, look, we value your support. We know that you still have a lot of role to play in terms of regulations, in terms of policies, in terms of, helping us ensure that there can be a good enabling environment for this kind of institution or facility to function. For the AUCDC, we had to approach them to say, look, we want you to help bring together all key stakeholders within the region. We are talking of the various, countries, their various health institutions, to see this as a Pan-African project. And we were able to succeed, with engagement, with involvement. It wasn't easy. We went through this over a 3 to 4 year period, but we got their buy-in, we got their interest, we got their support. And today we got the Nigerian government, for instance, with the first we are starting in Abuja, providing us with essential things like land, like incentives, financial and non-financial, to ensure the sustainability and viability. We got the Africa AUCDC, supporting the project directly and pitching the project to, regional governments, to governments and member countries to be able to buy in their support. So, bringing in stakeholders, partnerships is key. Bringing in governments, bringing in multilateral finance institutions and regional economic communities is vital to ensuring that we can change the healthcare infrastructure landscape on the continent. Thank you.
Thank you. Thank you. I had Richard. Were you wanting to make a point? Sorry, I think I missed a wave from you.
Yeah, no, that's okay. I was trying to jump in on the last point. So I guess my thinking was, and it's really agreeing with Nicholas and Paul about the government role. I think they absolutely need to be the guiding mind in what that healthcare system looks like across the country. And then, you set the vision, which the vision can be as strategic as you want, but at the end of the day, you deliver projects in manageable chunks. And what you need to make sure is that those projects that you deliver come together in a joined up and coordinated manner. Taking the digital disruption piece that I started with, if you put in place that digital infrastructure that then takes activity out of the hospitals, you then build a different hospital. But you can't build a different hospital first because it's entirely reliant on the digital infrastructure existing. So that is absolutely why I think the government should be the guiding mind of what it looks like and that mix of all sorts of infrastructure, and then make sure that the projects that are delivered within that framework come together in a coordinated manner. And it's only the government, I think, who can do that. In terms of the system of system thinking, you almost need systems thinking within the healthcare sphere, to coordinate that hospital non-hospital piece. But then the really massive opportunity, for further down the line, I guess, is when you really do start to think about healthcare alongside transport, alongside energy, alongside education, because when you look at somewhere like the UK, the impact of the built environment on people's health is much greater. And this might seem like something further down the road for a lot of countries, and I accept that. But the impact of how we design the built environment and all the things that contribute to that really can help start to reduce the healthcare burden at source. So that is where you can add the most value. The more strategic the thinking, the more joined up it is out with healthcare, the greater the value that could be added.
But then I was just thinking as you were talking, there's some stuff I was doing with a local authority a while back, and we were looking at simple stuff around how planning the environment or planning rules can impact on health. When you get to something as simple or relatively simple in terms of concept as saying no fast food outlets within so many 100 meters of a school gate for reasons to address issues around what people eat and how that affects their food, that in itself generates a huge amount of debate. Just in terms of thinking, as the concepts get bigger, which they need to, in my view, respectfully, in terms of how you think and what the strategy is. The difficulty becomes in setting that strategy. But then if you're turning up financing stuff, and the point that you helpfully made around, so you can't just build the hospital first and then do the digital. You have to have the digital and then you build the hospital. You build the hospital to fit into the digital. If you were then coming to somebody to fund that, and you say, right, well, we've got to finance that. Sorry, that you're going to have to finance. We want you to finance the digital, because then that means that you can finance the hospital, and that means that, and then you're then talking about a whole series of interactions, which are, for any private sector financier, start to become quite scary. I don't know whether anyone on the panel has thoughts about how that might be managed. Paul.
Yeah, thanks, Barry. I mean, I think partly I'd reiterate Richard's point, which is about doing things in bite-sized chunks. So you don't have to crack the whole nut in one go. It's thinking about how do we, from the vision and from the strategy, what are then the different components that we need to put in place, and how will we deliver each of those components? And some will be publicly financed, some will be privately financed, as entirely separate projects. So it's really about how you operationalize that strategy, I think, and make it deliverable. And just to make a sort of complementary point on finance, we often hear that the problem with investing in Africa is that there isn't enough finance, but actually the facts don't bear that out, right? If you look at how much institutional investors, for instance, have sitting in bank accounts because they don't find the right projects. I mean, I think by some estimates, it's something like $1 trillion of dry powder that sits in bank accounts of institutional investors looking for the right projects. What that tells me is that actually the fundamental issue is finding the right projects and preparing the right projects in the right way and bringing those to the market with the right conditions attached to them. So that, to me, is where a lot of the emphasis should be before we even start to think about financing.
And so, Olorante, and then I wonder whether Chris could make some comments from the point of view of someone who is presumably approached to equip or finance a project, and how that, so from that perspective. But Olorante, what point did you wish to make?
Yes, just to speak to what Paul had mentioned with regards to having bankable projects, that most times it is not just the fact that there are not enough financing on projects, but it is about finding the bankable projects. It is something that we've realized as we've tried to intervene in healthcare since 2015. So in 2019, we developed a project preparatory facility to offer financing to project developers to be able to develop feasibility studies, technical studies, even take them through the financing of their projects, meet their financing cost, because we see that this is a huge issue. If we can solve this, then we will be able to get more projects to be bankable and financed by a lot of institutions, both DFIs, ECs, even commercial banks. And it's not just Afreximbank doing this. I'm aware other development institutions are doing this across the continent too. You have DBSA also, who has a project preparatory facility. You have AFC with a project preparatory fund. And I know that IFC also have their own. But I think it's all of us coming together and pushing this out more would help us be able to really, step up and bridge the infrastructure gap on the continent. Thank you.
I see that. I mean, I see that not just in African countries, but I get a large number of so-called business cases cross my desk, and they are really a set of glossy slides explaining the need, which is, as I think you and I have had this conversation before, explaining the need, which is obvious. You can just know or read any newspaper to understand that, but not then really looking at the demand. And then the problem becomes the seed capital that is needed to move what is quite possibly a very good idea into something that can actually be delivered. And I think, and a lot of people then say, so where can I go for that? And I think some make question, do we think that some central organization or some way, is there a register, for want of a better word, or place where you can go to think, oh, well, I could go to African Development Bank, or I could go there, or is it quite arbitrary, do you think, Olaranti?
So right now there's no centralized place to go, and Paul will confirm. But what we are doing more, or what we are seeing more from DFIs, is that DFIs are now pushing out these products to support, preparation, project preparation, seed financing, early capital works financing, and it's all about getting it more out there. I doubt if we can get a centralized system. I know that there are organizations, there are efforts across the continents where we have meetings regularly in the year to look at projects. It's been led by the Africa Development Bank, the African Finance Conference, where we pull together a lot of these projects, look at it and see which ones can be financed by either Afro-Exim Bank, the AFC, or other like institutions on the continent. So there is no centralized pool, but DFIs are coming together to work on co-financing early stage works. So you get to see some early stage works being financed by, say, Afro-Exim Bank and IFC, or sometimes Afro-Exim Bank and DBSA. So it's that partnership that we do have on debt financing that we've carried into the project preparatory financing, and which I think we will continue to build up on. Thank you.
Thank you. Thank you, Chris. So from your perspective, I mean, there's the issues I think that people are talking about are quite common, and some of the points that have been elaborated over the past half hour or so reflect the points that you made in your initial discussion points. How do you see the issues that have been mentioned? How do you respond to those? And from your perspective, what makes a project that's sort of deliverable and financeable, which I suppose are kind of the same thing? But...
Sure. Thanks, Barry. Look, no one person can answer everything. That's the challenge, right? It's not only the government, it's not only GE. It's a combination of multiple banks and agencies to get things working. And the biggest challenge or hurdle to overcome is how busy Ministry of Health and Ministries of Finance are right now. That everybody's got multiple tasks. Most of our countries in Africa, as I said before, are heavily indebted. So, adding more hundreds of millions on hospital projects is always a very tough thing to do. But if you have the right government connections and they have a good vision and they have a good plan, then it's a connection or a collection of companies and individuals that can then help them realize that. It can't be GE on its own or one of the other banks on its own. It's got to be a very effective Ministry of Health with a good vision and that's prepared to perhaps listen and work with others to get it done. If you just go with standard procurement, you'll get what you've always purchased, which is some items, and that doesn't build a healthcare plan and it doesn't build infrastructure. A combination of an intelligent EPC, great banking facilities, good policy really, really helps develop healthcare. And I think people have mentioned vanity projects a few times. But vanity projects built in the eyes of some may have a lot of political credibility, but they do remain political and not necessarily completely linked to the healthcare systems of the country. So to change the healthcare infrastructure of a country requires a massive focus on primary care. Most of our countries have got great clinic networks. They're not all there, they're not all trained and educated, they're not all equipped. But just to focus on primary care, to go up into removing some of the burden from the secondary and tertiary hospitals would be a massive step forward. We don't have that in the UK. We don't have that in France. But a really solid primary and referral care network can be a massive benefit to any public health infrastructure. But it does involve a number of players. Government has to be a guiding factor and a visionary, and many private companies and institutions can provide input, as long as we're not hampered by some of the massive restrictions that we see. If you just go to tender on a whole bunch of things, you'll get a hospital built but not equipped. You'll get a hospital equipped but not maintained. You know, people forget about things like maintenance budget or training budgets. So I think good public-private partnership is a really great way to go forward. And GE is actively engaged in many of the countries in Africa to get that done. And we welcome the support and our support. We offer our support to the governments.
Picking up on a few points to be made, as you said, that so it may involve the private sector coming to government, people who know their way around working with governmental institutions in a particular country or group of countries. And picking up on what Ralph was saying, the context of the supply chain. So issue one, how do you, and from his perspective as a contractor seeking to engage with the UK or the French or wherever supply chain, and people being nervous about going into new markets. But if you take a further step and say, but so it's all very well for established, if you like, established players in the market to know their way around government in order to put forward ideas. But a lot of what we've heard from all the panelists has been around, well, we need new ideas, new players. And so, I mean, picking up on the point that Paul made earlier on, who would have thought a few years ago that a British originated remote primary care organization would be operating in Rwanda? Who would have thought that an American or originated company would be offering drones to supply the pharmaceuticals in Rwanda? Just picking on Rwanda because it's been mentioned as an example. So, but those are new players coming in to markets. Does anyone have any thoughts about how new ideas, new players can be encouraged to come into markets which they may be reluctant about? Or is this something that has to come from the government or has to come from the established players? Any thoughts, anybody really? Nicholas, I see your hand.
Yeah, thanks very much. So we receive quite a lot of what we call unsolicited bids.
Yeah.
Where people who have had experience in other countries and tested things in a different framework try to come and do the same thing in our country. And sometimes it fits in with our plans and sometimes it doesn't. Sometimes we like it as the health department, but we need to convince players in other departments that, like public works or treasury or whatever, that there's a different way to do it. The bottom line for us is always, how are we going to pay for it?
Yeah.
And even public-private partnerships have to be paid for. And if you're moving towards a national health insurance like us, where everything is ultimately paid for with tax, it means we're going to pay tax. And the taxpayer wants to see a return on investment. And that return on investment is not measured the same way when you're talking about healthcare, because we see healthcare as a public good, not as a tradable commodity. There may be tradable commodities that are used to deliver that outcome. But for us, we're worried about outcomes. We want healthy people who are gainfully employed in the economy and can contribute to society. And the only way to do that is to make sure that you don't limit their access to the health system by requiring them to pay. So who's going to pay? So you need to be working together with the country's financing mechanism. We heard that some countries spend 2% of their GDP on healthcare. Some are even less than that. We spend 8.5% of our GDP on healthcare, and we've got amongst the worst health outcomes in Africa. Why? Because we spend half of that 8.5% in a private, demand-orientated money arrangement, where the private sector is run not on the health outcome, but on how much money can I make? What's my profit margin? And if you undo that and go back to a system where we all have access to everything, and there's still room for the private players, is going to be a long and tall ask. Thanks.
I'm wondering, as we're moving towards the end of the session, whether anyone would like to make any. Ralph, I was wondering whether there are any points that you wanted to make, that the various items have been made in the questions or the general conversation. Are there any sort of themes that sort of strike you or have chimed with you that you think that we should be looking at a bit more, or any other points you want to make?
Just to, it's a joint force here. So government, private sector, us all needs to work together to change this whole picture. And as a Brazilian, we face similar overwhelming system issues in Brazil, and we can understand what is what's happening in Ghana or Africa itself, because we face the same challenge, and as you could see. And one example that I like to use, which is why do we need to buy a simple example? Why do we need to buy a automatic, full of buttons, state-of-the-art bed if we can buy a mechanical, which will have the same functionality, and it will not demand maintenance in the future or spare parts, where it will pay a third of the price. Do you know that? So yeah. Small things, simple minds, and it will be, I think, this changing this mentality, and I think we can make the things bigger. Yeah.
So just picking up on that, one of the complaints I have heard in conversation is that when consultants from developed health economies are engaged, and I'm sure this doesn't apply across the board. In fact, I'm sure it doesn't apply across the board. But one criticism I've heard is that the solution that is offered is, if you like, a solution with all the bells and whistles, and which assumes that the underlying support in terms of your point, Ralph, the underlying support in terms of training and in terms of maintenance and such like are there. And so whilst that might, while some sort of private hospitals may wish very much to promote that everything is state of the art, do you see that, do you find a difficulty and then say, we don't want state of the art, we want state of the doable? Is that an issue you often come across, or how does that work for you, do you think, in terms of what you're being asked to procure and how you procure?
No, it's not an issue, because we have all this. We have all the supply. We have suppliers for everything here. Yeah. Mm-hmm. So the state of the art and the average one, which is, as I said, it will be suitable as well. But I think it's not a challenge. This thing, I think, is a challenge to convince that this in both cases they work well, and I think it's a waiting game, but this needs to be changed.
Yeah. As we are coming up to 11:30 in London and 11:30 somewhere else, wherever people are, could I just, does anyone want to make a point? I'll just sort of go in, I'll go in reverse order from the people who the panelists who originally spoke. And there's no, if there's nothing what you wish to add, just say there's nothing I wish to add, but because I didn't warn people of this. But Oloranti, is there anything you wish to add?
Well, you didn't warn us, so I'm just going to pick something up.
I didn't warn you.
I think one of the key things I got out of this session is the need for collaboration, both from the government, the public sector, the private sector, financiers like ourselves, DFIs, all putting our heads together to be able to, come up with solutions. And these solutions may not be grandiose. They may start with small solutions that could fit in with what individual, countries' infrastructure needs are, and just to have efficiency at the core of what we are doing, and to be able to, work together to get things moving. So I think these are the key things I got out of this session, and which will take with me going forward. Thank you.
No, thank you. Nicholas, any further thoughts?
I just want to support Ralph's point that he's just made, and that is this fixation we have with standards. And in the African countries I've worked in, if the standard is not a CE standard, or the FDA said this, or somebody else said something else, then it's not good enough for us. And I think we are making a big mistake. And if there's something we should do in Africa, it's to start to set doable, practical, sustainable standards for Africa. And sometimes leapfrogging means that you get the newest technology. And sometimes it means the old technology is what works best. And so if you have a lot of people who are into computers and electronics, and you have a lot of power and a lot of whatever else, you can go for all the electronic gadgets. But personally, I want a motor car where I can still wind the window handle, because I live and work on a lot of dirt roads. And that electric window winder is constantly a problem. I don't want a motor vehicle that has all of that stuff. And I think that's the point that Ralph made just now. You need to, in the specifications of the buyer, and particularly if it's a public sector buyer, state of the art is not always better standards. Thank you.
That's really helpful, and creates a more financially sustainable project, because you're not spending money on what you don't need to spend money on. Paul, do you have any contribution you want to make at this point?
Thanks, Barry. Just two, I think, final words from me. One is political will, which we've not really spoken about very much today. But it is critical that if we are to secure private sector investment in many of these countries, then we need that political will. And related to that is political stability. So again, if we're entering into long-term financing arrangements, long-term PPP contracts, for instance, then that stability is an absolute necessity. And what that means is that we can't have projects driven by a single minister. We can't have the health minister saying, I want to shine a new hospital. There has to be wider buy-in from the government for that direction and for that investment. So that I will leave those thoughts with you.
No, I think that is an absolute key. The whole thing about long-term and having confidence that the project is real and will continue. Both at the, I think, probably at the whether people are going to invest in investing in that project, and the long-term issue around financing it. Absolutely key, and an issue we've seen in not only in developing healthcare economies, it's a very real issue around political will across the board. Chris, any thoughts?
Just a few, maybe, Barry, just to kind of finish up on what Nicholas and Paul have been saying. Look, Africa is an amazing continent. Without question, there's a lot of need, but there's a lot of people that know how to work on the continent and have proven track records. I think don't be scared of working in Africa. It's an amazing place with amazing potential. We fully endorse what everybody's been saying about the right product for the right time. It's essential that we do that. And G Healthcare is here to support the African continent. We've been there for the last 15 years, and we'd like to be there for more than the next 15. And encourage as much participation in events like this as possible. There are a few people around this call and others that know how to work in the territory and know how to make things happen. And we encourage that collaboration. It works, and it can work for governments. And if it works for governments, it means you have a working or a better healthcare facility. And that's great for outcomes and great for patients, which ultimately has to be our objective.
Ralph, any thoughts?
Well, thank you very much. I think it's being part of this panel and being part for this Africa investment group, and to change this this moment is really important to us, and I'm proud to be here with you all. And that's it. Thank you very much for the opportunity again.
Thank you, Ralph, and thank you, Ralph, for participating. Richard, you led us off. Why don't you finish us off, as it were?
Well, just one final comment from me then, to reiterate. I think the answer probably is a mix of public and private, but don't let that confuse the overall need for the government to set the vision and be the guiding mind in terms of what that healthcare system needs to look like. So I'll just end on that note. Thank you.
Thank you very much indeed, and thank you everybody. Thank all the all of those on the panel. Thank you very much indeed. And thank you for all the questions that have been coming in. I hope I've covered them in one way or the other, or most of them. I hope no one feels that they asked a question which we didn't cover in some way, but I'm sure emails on outstanding points, I'm sure we'll be able to look at and come up with comments if anyone would like us to do so. Steve Gardner, do you want to sort of close this session down now?
Thanks very much, Barry, and thank you to all of the panel. Thanks, Barry, Paul, Nicholas, Chris, Olaranti, Ralph, and Richard for what I thought was a really great and really interesting session. Certainly, for the last hour and a half, my job has been to monitor the chat and send all the questions to Barry. So, been really, really impressed by the amount of interaction that we've seen. Clearly, people have got an awful lot out of today's session. If you want to watch it back, it will be available throughout the festival. On the page for this session, you'll be able to watch back the session and read the chat comments throughout. The chat will remain open as well for anybody that wants to continue the conversation afterwards. So it only says that falls to me to say thank you again to all of you for taking part. We have another 5 sessions coming up at the Healthcare World Festival. We have our digital healthcare session tomorrow, so that links actually quite nicely to some of the things that have been coming up in this section. Now, infrastructure is about everything. Digital healthcare is a key part of how we deliver infrastructure to deliver healthcare. So same time, same place tomorrow for our digital session. Thanks one more time to the panel. It's been great to see you all, and thank you all.